Our next speaker is Dr. Sony George. Actually, he'll be talking on EDOF IOLs, the new paradigm in presbyopia correction. Actually, Dr. J.K. Reddy was supposed to come, but then because of personal reasons, last moment he could not come. So Dr. Sony, yesterday I requested him and he very volunteered to take the topic. I'm really thankful to him. Dr. Sony, as we all know, he is the HOD of Cornea Cataract and Refractive, Vasanai Hospitals, Cochin and Thrissur. Over to Dr. Sony.
Thank you, Dr. Anu, for the kind introduction, and thank you for giving me an opportunity here. I'll be talking about from where Dr. Srini stopped. EDOF IOLs, I would like to acknowledge and pay homages to my mentors, Sai Murli and Dr. Sundaramurthy. So why EDOFs? It actually started when the reading distance started receding. With the onset of computers, laptops and everything, the normal reading distance of around 33 centimeters, which our fathers used to read or we used to read in our younger days, it started receding. Now we don't even hold our mobiles at 33 centimeters or our books at 30, it comes to around 50 centimeters. And with the onset of the IT profession, people started rethinking about the distance at which people read. And second, the most important problem with the multifocals which used to give N6 vision was the photic phenomena. So something which reduces both reduces the photic phenomena, at the same time gives a functional near vision or intermediate vision was the reason why EDOFs came into place. So these are the different types. The type 1 is what Dr. Srini talked about, the pure spherical aberration based correction, and the one which on the pinhole principle. And then we have the refractive diffractive with the low near vision add. The first one to come in that range was the AT Lara. And then the hybrid multifocal EDOFs, which have lower near vision and manipulation of the spherical aberrations on the surface, and the modified central optic profile or the X EDOFs, which the Vivity and now the Hoya Impress are all about. So, like I said, the spherically modified is already, Dr. Srini is covered, IHAN, Swisphobe, Ray1 EMV, and the refractive diffractive is the AT Lisa, the Vivid from Orolab, which is again a wonderful lens, the Symphony and the Synergy, and the X EDOFs, the Vivity and the Impress. So these are all based on the functional working distance, and I'll skip this because Srini talked about it. Swisphobe in my hands works very well, and it is comparable to the Minivel IOL. And it's got an anterior refractive optic element and which gives excellent distant vision and negative aspheric design in the periphery, just like any other negative aspheric IOL. And this is what the lens looks like. And I do micro mono vision, and I get good in near vision also in this patient. I'm skipping this. Okay, this is the AT Lara. So this has the light bridge optical design. So the near ads come in, or the intermediate ads come in lower ones, 1.90 and 0.95, and they get a continuous range of vision from 50 to 60 centimeters. So the light is distributed at 50 for distance, 15 for intermediate at 0.95 diopters, and 35% at 1.9 diopters. And this is how the lens looks like. It works very well. Intermediate vision is pretty from a range of around 50 to 70 centimeters. It works very well. Nearer than that, it is difficult. And the Auroview Vivid again is one such lens. See, if you look at the lens, it's got a central area of 1 millimeter. That is the refractive zone, which has got a diameter of 1 millimeters. And on either side, you have a diffractive zone of 2.1 diopters. So totally it makes 3 millimeters in the center, which is modified. And so it is an attempt to get our, see, this is the normal, the green one is the monofocal lens, and the red one is the multifocal lens, and The vivid covers more of intermediate, a little bit of near, and at the same time, if you look at the left-hand side, the visual distortions and the photic phenomena are minimal in these lenses. So this is the lens being injected. It is, if somebody has used a defined lens, it is similar to that. And the lens goes through a 2.8 millimeters. They are trying to reduce the incision size and the injector system. So after injection, you can see the central 4 rings, which is confined to the central 3 millimeters. These lenses you should always wash under the lens so that the tackiness remains and the lens sticks to the posterior capsule and reduces the PCO formation as well as the centration. I'll skip this. And this is how it appears in the postoperative period, a very well centered lens. And in my hands, almost with micromonovision, the patient achieves almost 6 N6 is around 70% of cases for near and almost 100% N6 for intermediate. Yeah, and visual disturbance are hardly anything. Nobody complains of glare or flare. The other, the ex-EDOFs, which I am talking about, is one is the Vivity. It is got, again, it's only the central 2 millimeters which is being modified. And here you have a smooth plateau of around 1 micrometers height, which is around the central 1 millimeter. And this stretches the wavefront and thereby provides a continuous extended focal range of vision. And the center portion shifts the wavefront forward to utilize all the available light energy. And this is what exactly happens. The stretching in the periphery and the shifting in the center. This basically gives a continuous range of vision and a reasonably good range of vision. And this is how it compares the monofocal this thing and the multifocals, and this is compared almost to the accuracy of IQ for the photic phenomena. So if earlier we needed to give a lens for a person who drives, we would have thought 100 times, but now Vivity is a lens we can safely implant in a patient who drives even at night. And in my experience, this is the lens, how it looks like. You have the central bump, okay, the plateau, and then the hole in the center. And the loading, everything is in the typical accuracy of platform. And this is the injection. It goes through 2.2 millimeters. Now all these come in the Clarion platform. Yeah, and this is how the lens looks like. And this is the lens just to show the centration of the IOL post-surgery. You can see the rings and not the ring, the plateau in the center. And this is how the lens looks like post-operatively. You can, on slit lamp, you can see the rings very well. And in my experience, I do a micromonovision. I'll come to that after finishing the next lens. The next one is the Hoya Impress. So here, again, they have done almost the same kind of correction in the center, but not the plateau and the central this thing, but they have made modification in the central 2 millimeters. But all the transitions or the variations happen in the subsurface area. So the surface looks very smooth. Only the subsurface area, the modifications have been made, and like you see, there is an extended range of vision in these lenses. And this, like Dr. Srini said, the Hoya lenses are just wonderful because of the injector system. It's almost 100% foolproof, and you can adjust even how much of the tip should go inside the incision. So that's wonderful. Like you can place it where, if you want to place it directly into the bag, it's very easy to do that. And this is how the lens goes in. So I'm just trying to stabilize the eye, and then once it's very easy. You can either go for the rotation or the push. I am always a fan of the push mechanism because you can use it in a single-handed. Otherwise, you have to come out and then start screwing. And in a patient who is under topical, if he moves a little bit, you're in tough situation. So it just goes in very smoothly into the bag. Actually, you can use. There is a small tip. If you turn it a little bit, you can use that to engage and put the lens inside. So. Yeah, this is again another lens which goes in the similar way. So for me, there are two protocols. So a patient who generally prefers a reading distance of 50 to 70 centimeters, and he doesn't need to come near, I would make him immetropic in both eyes. That is the protocol 2. But most of my patients would say, I would also like to read. And here I aim at immetropia of around 0.25 in the dominant eye or 0, depending on the reading this thing, and 0.5 to 0.75 in the non-dominant eye. This way it works very well, and almost 100% of the patients are able to read N6 at a distance of 40 centimeters and with reasonably good illumination. You have to stress upon the fact that you need more illumination because the light is split, so you need more light. In the other protocol, immetropia in both eyes, they still can read, but with very good illumination, maybe around 50 centimeters. So this is how I go about with my EDOF IOLs, and I think it's definitely a promise for the future, especially with the number of people, even ladies who are in the cataract surgery age group who are still driving and active, even driving at night. Thank you very much.
Thank you, Dr. Sony, for that wonderful presentation. My one doubt here is how would you go about going with EDOF lenses and all in post-refractive surgery cases? And maybe Sachin can add on to this, because from what I understand, Shah Rukh Khan created all these ruckus because he was implanted a Vivivity and he had undergone a hyperopic LASIK. Hyperopic LASIK. So if a patient has undergone LASIK, Sajjan, like if it is a myopic LASIK, that induces more of negative sphericity, right? And you are adding that. See what happens in those cases if you are putting an EDOF, enhanced monofocal, and what might have gone wrong in Shah Rukh Khan's case?
There is a joke about it. You know about that, right? He insisted on the SRK formula.
Sajjan, your comment.
I don't think hypermetropic LASIK in the first place is a good idea. I mean, I don't recommend that much.
Exactly, that was what Srikanth was telling today morning. With that, have a lot of photic phenomena, even otherwise. Yeah.
So after that, to put an EDOF on that, I mean, that will be like, and especially in Shah Rukh Khan, I mean, you have to be very, very careful. That's what. I mean, it is a difficult situation. Hypermetropic LASIK and then to put an EDOF, I don't know. I mean, there is no clear-cut answer to that.
Yeah, if it is a normal myopic...
myopic LASIK, it is okay. It doesn't matter much. Yeah, because you can behave with normal IOL, that selection with the Barrett's formula, I don't think you have to think much about that. Yeah. Only the hypermetropic LASIK is the issue. I mean, people who have done the LASIK after 40 for the presbyopia, that is where the issue comes. Yeah.
Okay.
I think any person who has undergone a refractive surgery, you have to be very, very clear that there is always an error of a residual chance of having a residual error. How much ever precise you are, whichever formula you use, you will still have. And you have to motivate them accordingly, spend more chair time. Most of the time, they will accept it. I've done a few cases. But then you have to be very clear about it. Otherwise, the chances are always there that there can be error. Even if you have all the pre-K values, everything, still there can be a chance of error.
So
Okay, we can have
Yeah.
more discussions, but
those just one thing, for those such cases is what they are promoting, the light adjustable lens.
but the feedback for right adjustable lenses from US is extremely.
It's not very easy. It's very cumbersome, but then